pressure. Musculoskeletal, as I stated in the very first part of lecture, can be assessed as you're watching the kid be brought in from the waiting room into the hospital or the ER or in the clinic. So watch their gait. Do you see any obvious anomalies? Does the kid have bowed legs? Are the toes turned in? If they come in with trauma, do you actually see a discrepancy between one side versus the other, especially if it's a fracture? Are they coordinated? Because they should be. By the time they are walking and running, they should be well coordinated. Fractures we'll talk about when we get to musculoskeletal, but the assessment is very similar to adults. Do they have any swelling? How is the strength? And you want to compare. If they have fallen down and they're complaining of arm pain, you need to have them squeeze your fingers right side versus left side. Is it the same? And you also need to test their sensation. Does it feel the same? And then we have to test the developmental milestones. So all the information that you have populated on your pre-class preparation that was given to you in December, you need to put that into place when you're doing an assessment. Have they reached the milestones that we expect them to? The neurologic assessment is very important for a variety of reasons. We need to pick up problems early. The earlier we detect something, the earlier we can do an intervention and maximize the potential of a child. Remember, their brains are not fully grown. We'll check their LOC. Now, how are you going to check the level of consciousness in a newborn? Is it going to be the same as somebody who's 16? Absolutely not. How are you going to get that baby to wake up? Well, basically what we do is we do a little noxious stimuli. We can just do something as simple as unwrapping them, taking off their diaper, running our finger up and down their foot, running our fingers up and down their spine. And that's enough to make them wake up and look at you like, what the heck are you doing to me? Their cerebellar function. When you watch this child walk and climb or crawl, are they doing it equally? Or do they have a broad-based gait and are they waddling? Have they reached their developmental milestones? We do our cranial nerves. They're the same as they would be for an adult, so review this. You had this in 172. Now, something that's very different is going to be the fontanelles. So the fontanelles is what your parents probably called a soft spot on the baby, and it's because the baby's cranium has not fully grown and fused. So we use the fontanelles as an assessment tool for increased intracranial pressure as well as hydration status. When it's bulging, we worry that they have increased intracranial pressure. When it's depressed, they may be dehydrated. We have a variety of reflexes that are present during the infancy stage into early toddlerhood. And you need to be very familiar with these because you will be doing assessments of newborns on admission or in the clinic. So look these up in your textbook. We're going to review these again when you're in 174. So the developmental assessment is done when the child is in the clinic. And the standard tool is the Denver Developmental Assessment Tool. And we use this until the child is age 5. You can Google this assessment tool and see the wide variety of things that we do. Some of you will be going to the Orange County Family Support Network outreach event, and you will see the physical therapists and occupational therapists actually doing the developmental assessment test. And here is a pearl that was given to me by a very excellent pediatric neurologist. It is a problem or a red flag if development is regressing instead of progressing. And so we will have this occur when a kid has a brain tumor. The mother will say, they were able to go play baseball and run the bases, and now they're having a hard time walking to school. They're all of a sudden waddling, they aren't interested. Well, in our minds, we're thinking, uh-oh, there's something wrong going on with the nervous system. So last but not least is the sexual maturation assessment, and we use the Tanner scale. And so you do need to know that this is available and that we assess this. There are going to be children who have what we call precocious puberty. They go into puberty when they're 5 or 6 years old. And so what we'll see is that they actually have pubic hair, axillary hair, they may have breast development, they may have elongation of the penis, the testicles are growing, and so we use the breast, pubic hair, penis, and testes to be able to determine where they're at in sexual maturation. The same can be true if they have a disorder where they are not developing. If they're still at Tanner stage 2 and they're 18 years old, we have an endocrine problem. So this ends the lecture on physical assessment of the pediatric patient.